was thought that is a fascicular VT. As you know, fascicular VT is a ablatable VT. So when we are going for the ablation, we can just do and it will be cured. In this case, first time when he was been given, usually the calcium channel blocker and beta blocker as a therapy for the fascicular VT. So fascicular VT, ECG is the enough. ECG diagnosis plus you have to show that echo is totally normal. So echo, normal ejection fraction, no structural heart disease, and you are getting a right bundle branch block with left axis deviation. If it you are getting, you can directly diagnose this is a case of fascicular VT. So in this patient, the coming to the what Usman has presented. So one by one, I will just bring the ECG important features. So Mr. X, which is 58-year-old, two admissions. One was in the month of April 16th, and he was discharged on 18th on the calcium channel blocker. Again revisited, admitted on 6th, and he was there till 12th. And that time his ejection fraction has dropped. So palpitation was the main complaint. He was not having any giddiness or syncope. If giddiness and syncope is happening with wide QRS tachycardia, it is taken as a diagnosis of hemodynamically unstable VT. So whenever you are going to see a patient with wide QRS tachycardia and patient is collapsing and later on you are putting a diagnosis of VT, this patient should go directly to the ICD, no ablation. Clear? So wide QRS tachycardia, which has been diagnosed as a VT, ventricular tachycardia, will be labeled as hemodynamically unstable VT. And this type of patient, we are not going to ablate even in the structurally normal heart. So in that situation, we have to put a ICD. And the reason is, we are putting ICD in those situations where we don't want the patient should arrest by the VT or by the VF. So to treat the VT VF whenever it is happening, if it is hemodynamically unstable VT, patient is tolerating it, he is not getting collapse. So we can study from where it is coming. If it is a focal, we can ablate and come out. But if it is unstable, patient is collapsing or arresting, we have to put AICD after the recovery. So palpitation, but not collapse. History of diabetes for some time. There is no fever, cough, SOB and syncope. So this all important. Fever we want means patient may be having a history of myocarditis. Patient may be having cough, cold, maybe a post myocarditis, a post viral illness associated myocarditis can be one of the possibility. History of SOB means breathlessness. Why we are keeping? Patient may be having heart failure also. So heart failure patient will be having, and then patient is having giddiness or palpitation. It means the patient may be having structural heart disease. For that, evaluation and treatment will be different. And history of syncope and collapse means hemodynamically unstable. So these all four component what Dr. Usman has taken is very, very important for making a conclusion regarding the behavior of this arrhythmia. And that time when he was stabilized, the vitals has totally normalized, and the later diagnosis was ventricular tachycardia with normal ejection fraction, means it is a structurally normal heart with ventricular tachycardia. So management will be totally different. When angiography has been done, mild CAD means less than 50% stenosis. More than 50% stenosis we call as non-obstructive CAD. More than 70% stenosis we are telling obstructive. Okay. Now, this is the baseline after shock, means they are giving all therapy failed and the patient is having, you can see there is nothing very significant in this ECG. Everything is normal. Now, this is second ECG. This ECG you are able to see. So in this ECG, this is a very typical ECG of fascicular VT most of the time. So you can see right bundle branch block, V1 is positive. Are you able to see? इधर नहीं आ रहा है. So this is the V1 is positive. So let me, you can see here now. So this is the RBB pattern, means V1 is positive, and here you can see 2 and 3. So 2 and 3, what is there? Left axis. Because it is negative, na, left axis. So RBB with left axis, until proved otherwise, it is a fascicular VT in the white QRS. Very simple. So one VT, if you have to diagnose very easily, you have to see that. After that, you can show the AV dissociation is there or not. By seeing this, we can say AV dissociation is there. So this was the first part. Same Here the things has changed. And what is changed? Here 2, 3 AVF is positive and for V1 is positive. So axis has changed. RBV with the left axis, now RBV with the right axis. And date is, you can see, date is around 16, next day. So same VT, sometime going to the left axis, sometime going to right axis. Is it possible in fascicular VT? Not. Fascicular VT, it will be always in one direction. So, okay, it is fascicular. Then they have given, I think, Cardron, the things has improved, and patient was discharged. So that time diagnosis was fascicular VT, but the second ECG has not been cross-checked that time properly. And patient is having diabetes, no coronary artery disease. Patient was doing fine. Then he again get admitted on 5th uh, 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 June. And is it a sinus tachycardia? Hmm? Meghna is saying what they are discussing, huh? Huh? What is this? This is VT. For the first time, you may not be, heart rate is how much? 120. So this is called slow VT. You can see this is only QRS, QRS, QRS. And the excess you are seeing here, AVR is almost getting positive. So same RBB, right axis deviation. And there is no P wave. And this is almost regular. If no P wave, regular means not atrial fibrillation. It is a VT. It is a slow VT is going on. So this behavior is also very important. If void QRS tachycardia is going and slowly it is going, it is an automatic type of. There are three variants. Na? One is automatic, second is triggered, and third is re-entry. These are three mechanism of tachyarrhythmias. So this is automatic, means it is going on all of. There is no circuit for that. Now you can see what has happened here. RBB, right axis deviation, same VT. It is now faster. What is the rate? 165. So previous one also VT. Sorry, where it is. So this was discharge, and this is the first rate. This is also VT at rate of 120 when it is going at 165. The same thing, and the axis is again. It is not left axis deviation. It is the right axis deviation. Now see this one. What is this? VT or sinus? Again VT. This time heart rate is 126. We can think about sinus tachycardia, but again we are not seeing any P wave here. Okay? So slow VT is still going on. Now, what is this? Sinus? You can see P wave, clear cut P wave is coming. So the heart rate is now 58. So this patient has been loaded with Cardron. Slowly the tachycardia has reduced and then it is back to the sinus. Okay. Now, what is this? The patient ejection fraction has gone to 50% over the time. When he has come, that time ejection fraction was 25. So it has gone 50%. When I was called that time, I told clearly load with Cardron. And after Cardron, you can see what are the important finding. The QT is prolonged. Okay. And some ST elevation they are saying, but I feel that there is nothing ST elevations in this one. There is a non-specific, some T wave inversions are there in the lateral lead. You can see T wave inversion here, T wave inversion here. So this is when we are giving shock to the patient, sometimes this develop repolarization abnormalities. Now the same patient, this is sinus or VT? Sinus rhythm. Good. Now, this patient came to our hospital and he was having plan of two things. One was PET CT and second was cardiac MRI. Cardiac MRI for scar burden. We want to see any scar is driving this VT or not. Okay? Is it possible or not? Is it possible or not? Not understanding. Huh? Hmm? Come this side, but this side better. Huh? Huh? Okay. So, good question. Scar is something which will be which can develop in any place other than brain. Brain is usually after infarct scar can develop, but usually any subtle infection in the body will give some scar. When cut is there, after that you see the scar. In heart also, when there is a infarct happen, coronary artery disease, then scar forms. When person goes for the any sort of infection, maybe myocarditis or infiltrative heart diseases. Infiltrative means there is some infiltration is happening in the inflammation is happening, infiltration is happening, some deposit is happening like hemochromatosis. So there is a deposit of iron in the myocardium, and that will lead to the inflammation. That is called infiltrative heart diseases. So either of these two situations, there will be some scar formation will be there, and this scar is the reason for re-entry, because scar area will be having a slow conduction, and normal myocardium is having fast conduction. And any re-entry need only two things: two circuits having a different refractive period and different rate of conduction. So when one is going very fast, slowly, then so the what we are saying, snake is catching the trying to catch the head, it will be going on, so it will be totally rotating, and it will not break unless you are going to make what you call conduction uniform. So for uniformity, what we do, we just give a drug which is going to reduce the conduction in both, and later on it breaks. It enter. Hmm? Pardon? So it is the difference in the refractory period. This period means the which is conducting very fast will be having long refractory period, which is conducting slow will be having large short conducting refractory period. So when we are giving drug like cardron or amidron, it is going to work on the refractory period. It will work more on the slower one than the faster one, so it will become uniform. Okay. And when we are doing the ablation, we are increasing the gap between the head and tail. So there is a more gap will be there, the conduction will break before that it will be reaching to the fast pathway, like that. So we did the cardiac MRI, and cardiac MRI was showing the scar burden of 30%. So when the scar is more than 5 to 10%, they are candidate for putting the EICD. Here we are not going to ablate. And the reason for not ablating, because big scar area, we are going to do whatever best ablations. A lot of myocardia is going to be burned, and it will again produce the scar. Okay, this is the part two. And when the scars are too much, the result of ablation is not a curative one. When a focal area is there from where the VT is coming, you ablate it, the things are over. But when the it is a broad area of myocardium is involved, then the chances of recovery for you can curative intent of the ablation will be very, very less. Okay. Now coming to the important ECG aspect, which this case was. So this patient, if patient is having right bundle branch block with a left axis deviation, the other diagnosis is bifascicular block. Have you heard about it or not? So bifascicular means you will be having the same RBB, left axis deviation, and sinus tachycardia is going on. How you are going to differentiate? Sinus tachycardia with bifascicular block will be having the same morphology what a VT will be having, fascicular. So how you are going to differentiate? So there is some points which we should remember. So there are 4 points. If you are able to see those things, you can say it is a fascicular VT. If it is not, it's a bifascicular block with sinus tachycardia. Sinus tachycardia 170, 180, you will be good. So what are the important features? The important feature V1 will be having a RSR pattern, which is in the right bundle branch block. VT may it will not be there. It will be having R, small r and big R part will be there. So only monomorphic will be there. That is the first part. Second, the QRS will be very wider in the bifascicular block, because there is a typical right bundle branch block is happening. While when you are going to the fascicular VT, it will be relatively narrow. It will not be going more than 140. And the reason is it is a re-entry. It is not the whole when RBB is happening, it is a sequential activation of the ventricle. Left ventricle is contracting first, right ventricle is contracting later on. That's why the QRS is becoming wider. In fascicular VT, there is a re-entry is happening at the level of septum. So both the ventricles are being activated, but there is some disparity. That's why the QRS will not be that wide. It will be between 100 to 130 maximum to maximum. Okay, here it will cross 140 also. This is the second important point. Third important point is the V6 RS pattern, RS ratio. So this will be more than one, means in the case of bifascicular VT, bifascicular block, and it will be less than one in the case of fascicular VT. Anything which is coming from the ventricle VT, it will be always less than one. And only one lead you have to see whenever you are in the doubt, and that is AVR lead. If AVR is upright means positive, it is VT until proved otherwise. So if you are getting AVR positive, here AVR is positive, you can see. So it is a VT, it is not a VT. Okay. So these are the 4 points. Out of 4, any 3 is positive, you can say it is a bifascicular, it is a fascicular VT. If it is not present, it is a bifascicular VT. Coming to this patient, I think this part already have told. The second part is, it is not at your level, but when we are going for fascicular VT, we have to keep one more VT, which is called a papillary muscle VT. So papilla of the mitral valve will also give the VT, and septum where the fascicles are there, right bundle and left bundle are there also will be chances of developing the VT. So how to differentiate? It is coming from the papillary muscle versus it is coming from the fascicles. And the differentiation, there are some important key point. One is the age. So usually the age of papillary muscle VT will be above 50 years. Second is QRS. QRS will be wider in the papillary muscle. It will be more than 130. V1 will be having the R to R ratio monophasic. It may be having RSR pattern. But the second, this is not a very important point, but the most important point is one is age, and second is the what you call QRS duration. And since it is triggered, you are seeing the VT is coming at 130 heart rate also, which is not usually common in the fascicular VT. Fascicular VT is a re-entry. One beat break, after that is normal. It will not slow down. So when anything is coming slow down, it is usually automatic VT. So the papillary muscle are usually automatic or triggered. So their heart rate can be at the one time 170, one time 150 also, one time 130 also. But if it is a fascicular VT, its rate will be maximum 1 or 2. Means it may be 170 or 160. It will not go to 120 also, because the circuit is fixed. On that only, if it is running, it will be coming. Otherwise, it will not. It is not automatic. And usually the papillary muscle VT will be presenting with the VPCs more, and sometimes the slow. And this is one of the important aspect, means very less discussed. You have to see for the Q waves. If you are getting a Q wave in the lead 1 and AVL, then it is a fascicular VT. And if you are getting a Q wave in the what you call V1 lead, this is lead 1 and AVL. Lateral lead, it is a fascicular. And if it is coming under the V1 lead, it is a papillary muscle VT. And now going back to the, in this patient, you can see, you are seeing here Q waves. This is V1. So it is a papillary muscle or a fascicular? No, papillary muscle. And where we have to see, it should be seen in this ECG. This is the ECG, na? RBV with this one. So you are not getting any Q wave in the lead 1 and AVL. So it can't be fascicular. Fascicular, it will be having a Q wave here and here. And here you can see the smaller part which is dipping. This is a Q wave. So this is a posterior papillary muscle VT, not a fascicular VT. And differentiation point is, there is no Q wave in 1 and AVL, and there is a Q wave in V1. So now it is diagnosed that is a papillary muscle VT. And the question arises, why this patient is having one time left axis, other time right axis? Is it there or not? Fascicular VT we are not expecting. So this is also going, and the explanation is the last point. So papilla is having two papillas are there in the left ventricle, right and left. So you can see these are the exit. It can go from this side also, it can go from this side also. You are seeing this one, this is a papilla. Papilla 1, papilla 2, this is a posteromedial and this is a anterolateral. So when VT will be originating from this area, it can go, it can go this side also, both the sides can be. So this is an automatic VT which can exit. Usually the exit of the VT will be giving the axis. So if it is coming, if it is going this direction, it will be having left axis. If it is coming this side, it will be having right axis. And this is the behavior what we got in this patient. So first of all, there is an exit is changing in the same patient in the same time, sometime to left and right. RBB is fixed, which is coming from the right ventricle. The RS in the V6 lead is less than 1, means it is coming from the cavity. And finally, the QRS is more than 130. Again, it is going into the papillary muscle VT. And fourth important point is more than 50 years. So all the points are going in favor of papillary muscle VT, and that has been confirmed in our cardiac MRI. There are a lot of scar was there in and around the what you call papilla. So that was driving the VT. Okay. So today case was fascicular VT, and I think if any questions are there, you can ask. Usman, first from your side, what is the learning in this case? So 2-3 aspects learning. One is any slow VT can give an impression that you are dealing with a sinus tachycardia or atrial fibrillation. So in that you have to see whether the P wave is there or not, how is the QRS, and if at all you are not able to identify, always check the AVR rate. If AVR is positive, until proved otherwise, it is a VT. Okay, very easy to identify. Just see the AVR lead. AVR positive means VT. That is one point. Second point, in this we are having doubt about the fascicular VT versus papillary muscle VT, that we have clarified why it is not fascicular, why it is this one. So points are, what is the 2-3 points? One is age, less than 50, more than 50. Second is widening QRS more than 130. Third point, Q waves. Q waves, where it will be? V1 and AVR. If it is there, then it is fascicular. 1 and AVL fascicular. If it is V1, it is papillary muscle VT. And papillary muscle VT can have the exit in either direction, right and left. That's why the axis will be changing. Fascicular, most of the time, it will not. Fascicular VT, we are differentiating whether it is coming from the anterior fascicle, posterior fascicle, or upper septum. These are 3 places. So upper septum, no axis deviation. If it is from anterior fascicle, it will be having right axis deviation, left axis deviation. If it is having anterolateral, then it is posterior axis. So like that, we are going to differentiate it. So, but anterior fascicular will not go into posterior fascicle. Like that, it will not be there. It will be having anterior fascicle, because the re-entry, most of the time the circuit will be in and around, and the ablation also we are going to give in that particular territory. Territory means the location where the anterior fascicle is having a slow conduction, which we are going to find and later on ablating it. Okay. Thank you so much. Yeah.